Okay, we're going to focus on clinical manifestations of decayed diabetic ketoacidosis. Now, on a test, you have to make sure that you pay attention to a couple of things. Diabetic ketoacidosis typically occurs in type 1 diabetes, okay? It can happen in type 2, but more in type 1. And also, you want to look at your glucose level. So if you're on your exam, you see a glucose level of 300 versus 600, anything really over 300 points more to DKA. So again, DKA is more seen on type 1 diabetes. Okay? You're going to have your typical polyuria, polyphagia, polydipsia. And if you don't remember, we'll go over that again. Polyuria, you're voiding a lot. And remember, it's because you're losing a lot of glucose. Glucose will be dumped into urine, water will follow. So you're going to be peeing a lot. Actually, polyuria, and you're going to be peeing a lot. You're going to be dehydrated, so you're going to be really, really thirsty a lot. So you're going to be drinking a lot of fluid. Polydipsia, and again, you're unable to break down carbs. So you're metabolizing fat and proteins as an energy source. So you're going to be hungry all the time. So right there, polyuria, polyphagia, those are biggies. Drinking a lot, peeing a lot. So you're peeing a lot because, again, you're getting rid of a lot of water, which leads to what? Dehydration. Dehydration will lead to poor skin turgor, dry mucous membranes. So you make sure you know these for your exam, dry mucous membranes. If you look at your patient and have sunken eyes, that will give you another indication that they are dehydrated. Tachycardia, remember, you're losing water, therefore your fluid volume, I think we already have this here, will be decreased. So in order for the heart to maintain circulation, it'll pump harder, it'll pump faster. That will lead to tachycardia. Okay, and you've lost lots of fluid. So if you're from a supine to a sitting or standing position, you have to tell your patient to move slowly, or they will suffer from orthostatic hypotension. So again, make sure you remind them to move or change positions very slowly. You're dehydrated, you'll most likely feel tired, you'll be weak, complaining of some abdominal pain, nausea and vomiting. Nausea and vomiting will continue to lead to dehydration. Now, Kussmaul's respirations, make sure that you monitor for this, that you check to see if your patient is suffering from this. You're breathing more abdominal breathing than diaphragmatic breathing. When you're breathing rapidly, you're blowing off CO2. Now, if you remember this from, I guess we'll talk about this later on, acids and bases. Anytime you blow off CO2, you're getting rid of, let's say, acid, okay? Remember that increase in CO2 will decrease your pH. So that'll make you more acidotic. Hence the name diabetic ketoacidosis. So what your body will try to do is try to breathe out the CO2 to try to bring your pH to a more normal level. Okay, so if you were to do again something like a EBG, you'd see what their acidotic state is. The other thing that you want to check for is their breath. Is it fruity? I've heard a lot of physicians say it kind of smells like juicy fruit. If you were to smell their breath, it would smell like juicy fruit because of that acetone on their breath. And remember, you're getting that acetone from breaking down fats. You break down fat, you produce ketone bodies, and again, that will bring your pH down, causing a more acidotic state. And remember, the ketone is what produces that acetone smell in the breath. Okay? And a big one is an altered mental status. Are they acting weird, or are they not acting normal? Again, this has to do with the change in pH. Okay? Now, what do you do for these patients? A couple of interventions here that you really, really want to be familiar with. Number one, IV therapy. We already established that they're going to be dehydrated, they're going to be tachycardic, so you want to replenish that fluid volume. So you'll most likely give normal saline or half MS. This will again depend on what the physician orders. You will not make that call. You will give them IV fluid after you've established IV access, of course. This will hopefully decrease the tachycardia. Okay, so you might want to also do something like an EKG, make sure the heart is functioning right. So the whole purpose of this normal setting happiness is to bring their their blood pressure back up again and increase their fluid volume. Step number 2 would maybe to start IV insulin therapy. Now again, this will be determined by the physician. Textbook says 0.1 units per kilogram per hour. But again, this will be ordered by the physician. Now, when you start IV insulin therapy, you must monitor their potassium level. So you want to do something like a chem profile, chem 8, chem 7, so anything like that, anything that will give you a potassium value. Why? Because anytime that you give insulin, remember, let's go a little biology here. That's it. This is a vein, artery, whatever. Here you have a cell. And inside the cell you have intracellular fluid. And now here would be extra or outside the cell. Okay, so potassium is out here. It is everywhere. So let's say that the patient is already hypokalemic. Maybe their potassium level is 3.0. Okay? So they're hypokalemic already. You give them insulin. Once you give them insulin, potassium is going to move inside the cell. It's going to go from the extracellular fluid into intracellular fluid inside the cell. So this number, the 3.0 that you started off with, might now be 2.5. You have now put that patient into a higher likelihood of having some arrhythmias, dysrhythmias. Okay, so you definitely want to make sure that you check the potassium level before you ever start any insulin therapy. Because once you give that insulin, again, the potassium is going to move in. Okay. Number 4, you want to monitor the sodium level, because again, you're going to start them on some IV therapy. So if you bring it most likely won't happen because you're giving a normal setting, but if you're giving a half an S, you have a likelihood of decreasing the sodium level. Okay, if that happens, what happens? Well, you have some cerebral edema occurring, so you want to make sure that they are not hyponatremic. So make sure that that's good. If that is good, then you can proceed. So again, monitor sodium levels. Number 5, you're going to be giving them insulin, so you want to make sure that you monitor their glucose levels. Are you dropping it too low, too quickly? If so, you might have to give them something like dextrose to maintain that glucose level within a normal limit. The other thing is you don't want to drop the glucose level down too quickly because you can cause, again, cerebral edema. So you have 2 things to watch out for not to cause cerebral edema. Number 1, monitor your sodium levels. And number 2, monitor your glucose levels so you're not dropping it down too fast. And of course, last on our list here is watch out for fluid overload. They're going to be dehydrated, so maybe the doctor will say, give them a bolus. Well, you can go ahead and give them a bolus, but if it's a patient with maybe like CHF or renal failure, you give them too much fluids too fast, what will you cause? Pulmonary congestion, fluid overload. So in that case, again, a couple of other interventions you want to watch out for is peripheral edema, lung sounds, any crackles, jugular vein distension, frothy sputum. Are they having increased difficulty breathing? If so, what do you put them on? 2, change their position from a supine to a semi-Fowler's, semi-upright position, or an upright position. Questions?